Hi, Dr. Shmaila here. Today we discuss chapter number 5, that is active movement. The means voluntary movement. Our learning objectives. What are active movements? Classification of active movements. What are free exercises along with their classification, technique and effect and uses. Besides this, assisted and assisted resisted exercise will also be discussed in detail along with the principles, technique and effect and uses. No. What are active movements? Movement performed or controlled by the voluntary action of the muscles working in opposition to an external force means that a person perform the exercise on his own pace. Classification: pre-exercise, assisted exercise, and you can say also assisted resisted exercise and then resisted exercise. Pre-exercise: the working muscles are subject only to the force of gravity acting upon the part moved or stabilized. Assisted exercise: when the muscle strength or coordination is inadequate to perform the movement, then an external force is applied to compensate for the deficiency. Resisted exercise: the force of resistance offered to the action of the working muscles are artificially and systemically increased to develop power and endurance of the muscles. Now, first of all, we discuss pre-exercise. What are the pre-exercise? Definition: pre-exercise are those which are performed by the patient's own muscular effort without the assistance or resistance of an external force other than that of the gravity. Extent of nature: they vary widely in character and effect not only because of the nature and extent of the movement but according to the manner in which they are performed. What are the characteristics of pre-exercise? This type of exercise can be used to obtain any of the effects which are produced by an exercise as a whole if and when it is used judiciously. If we use it judiciously, then we obtain desired effect. Obviously, when we perform pre-exercise, a degree of relaxation is induced by the exercises which are rhythmical or pendular in character. Muscle tone is maintained. Power increases according to the speed, leverage, and duration of the exercise and relationship of the part moved to the gravity. Coordination is trained or improved as the natural pattern of the group action is employed. Further, the confidence in ability to perform and control movement is established. Success in achieving the required effect depends not only on the selection of a suitable exercise and on the manner in which it is performed, but also on the degree of the cooperation obtained from the patient and the skill of the instructor. Now, what is the advantage of pre exercise? The great advantage of the pre exercise lies in the fact that once the patient has mastered the technique of their performance and is aware of their purpose, there is on to practice when and where he pleases. He has, in fact, been given the means to cure or to help to cure himself and need no longer rely on others for his purpose. Whether or not he uses the exercise for home practice to help himself largely depend on his desire for rehabilitation and his confidence in the efficiency of the exercise. And what is the disadvantage? The disadvantage of pre-exercise is that they frequently make insufficient demands on the patient neuromuscular system to elicit the maximum response required for the rapid redevelopment or reinforcement of the weak muscles. When there is muscle imbalance, compensatory rather than the normal patterns of the movement may be used unless movements are carefully taught and carefully supervised. Patients who have suffered brain damage or who are unable to initiate movement cannot cooperate in doing these exercises until their performance has been facilitated and until voluntary control has been established. This is the big disadvantage, that because the pre-exercise make insufficient demands on the patient neuromuscular system. Look at these exercises, free exercise examples. Classification of the pre-exercise. Classification of the pre-exercise, it may be classified according to the extent of the part involved into two parts: localized and generalized. Localized exercises are designed primarily to produce some local and specific effects. For example, to mobilize a particular joint or to strengthen a particular muscle group. Movement is localized to one or more joints, either by the use of a suitable starting position or by the voluntary fixation of the other areas by the patient's own muscular effort. Localized means specific to an area. That means you have to produce some local and specific effect. For example, to mobilize particular joint or to strengthen a particular movement. Generalized exercises usually involve the use of many joints and muscles all over the body, and the effect is therefore widespread. For example, as in the case of running. The character of a particular exercise may be subjective and it may be objective. Basically, exercise which are subjective are usually formal and consist of more or less anatomical movements performed in full range. The attention of the patient is deliberately focused on the form and pattern of the exercise to ensure accuracy of the performance. Look at the example. Your sitting position, then arm bending and stretching sideways and upwards. As many of these exercises are artificial and bear little attention to natural movement, they are now used to a lesser degree than formerly. Some, however, may be useful in establishing a correct pattern of movement and avoiding the tendency to develop trick movements, which is often functionally effective but wasteful of energy in comparison with the correct pattern of the movements. Objective exercise. Objective exercises are those during which the performance of which the patient's attention is concentrated on the achievement of a particular goal or aim which will result from his efforts. For example, standing, arms stretching upwards to touch a mark on the floor or to throw a ball, because aim is set in objective exercises, while in subjective exercise their effect is generalized. No aim or goal is established. The presence of a goal to be reached is stimulating to the effort, but care must be taken to see that accuracy of the movement is not sacrificed to the achievement of the aim. For example, in walking across a room to get a cup of the tea, then quality of the walking must not be allowed to deteriorate. Now come towards technique of the pre-exercise. Starting position is selected and taught with care to ensure the maximum posture efficiency as a basis for movement. First of all, is whenever you perform any exercise, then a starting suitable starting position is basically selected. Then instruction is given in a manner which will gain the interest and cooperation of the patient and lead him to the understand both the pattern and purpose of the exercise. Speed at which the exercise is done depends upon the effect required. It is usually slow during the period of learning, and later the patient is either allowed to find his own natural rhythm or the speed required is dictated by the physiotherapist. It often helps the patient to maintain his own natural rhythm at home if during practice under supervision he is encouraged to count loud. The duration of the exercise depends very largely on the patient capacity. Usually, 3 bouts of the practice for each exercise with short rest period or a change of activity between ensure sufficient practice without undue fatigue. So there are 4 steps that we discuss in technique of the exercise. First of all, starting position is selected. Then instruction is given to the patient to gain his cooperation. Then speed at which the exercise is done depends upon the effort required. Speed must be slowed in the period of learning, and when the patient is used to of it, then slowly speed we increase the speed. The duration of the exercise is to depend upon patient capacity. The indication of active pre-exercises. We use active pre-exercise in the case of muscle weakness, after removal of the breast cast, following surgical procedure, tendon or muscle transplantation, muscle re-education. If there is limitation of range of motion, then we use free exercise, cardiovascular, respiratory disorders, inability to do basic functional ADLs independently, activities of daily living ADLs. What are the contraindication of the active pre-act movements? Immediately after cardiovascular disorder, for example, myocardial infarction, angina pectoris. Immediately after recent tear to the ligament, muscle or injured joints. At the site of the fracture, recent surgical procedures to the tendon, ligament, muscle, joint capsule or skin. Diseases of the bone, for example, TB, and pathological, for example, osteoporosis and TB, tuberculosis of the bone. If there is acute joint inflammation, then it is also contraindicated. Acute muscle inflammation, muscle swelling, severe joint pain, acute muscle pain, these are all contraindication of the active free movements. No, what are the goals of active free exercise? Goals: to improve circulation, to increase rate and depth of the respiration, to mobilize stiff joints, to improve range of motion, to strengthen weak muscles, to improve coordination and balance, to achieve ADL, then to correct deformities, to improve posture, to improve gait and ambulation. These are all aims of free exercise. What are the factors and juices? It basically depends upon four factors: nature of the exercise, extent of the exercise, intensity of the exercise, and duration. First, relaxation. Rhythmical swinging movements and those which are pendular in character assist the relaxation of the hypertonic muscles in the region of the joints moved. The alternating and reciprocal contraction and relaxation of the opposing muscle groups, which is required to sustain the movements, help to restore the normal state of relaxation which follows contraction. This type of exercise is used in conjunction with other methods to reduce a state of wasteful tension in muscles, which limits the range of joint movement and reduces the efficiency of neuromuscular coordination. Exercise which work particular muscle groups strongly achieve a reciprocal relaxation of the opposing group. For example, work for the scapular retractors and shoulder extensor assist relaxation of the pectoral muscles. As you see that they are basically opposing muscle groups. Joint mobility. The normal range of the joint movement is maintained by the exercise performed in full range. If and when the range of movement is limited, rhythmical swinging exercise incorporating over pressure at the limit of the free range may serve to increase it. Muscle power and tone. The power and endurance of the working muscles are maintained or increased in response to the tension created in them. This tension is greater when the exercise performed at any speed which is slower or more rapid than when the natural speed of the movement is employed, and it increases with the duration of the exercise. A high degree of the tension and consequently increase in the power can be developed by the free exercise when the muscle work for any time against the resistance offered by the body weight or against the mechanical disadvantage of an adverse leverage provided by a long and heavy limb. Normally, muscle power is maintained adequately by a minimum of everyday activities, most of which are performed in the middle range. Under abnormal conditions, However, for example, during fixation of a joint, the power can only be maintained or improved by repeated static contraction, which the patient must practice throughout the day. Look at this. Static contraction means isometric contraction. In this example, patient performing quadricep isometrics because quadricep muscles mm, atrophy and rapidly go into weakness, while the hamstring muscle are more sustainable to tightness. In this example, a rolled towel is placed under the knee, and we have to give instruction to the patient to press his knee down towards towel for 5 seconds or 6 seconds and then release and repeat it a whole day. Neuromuscular coordination. Coordination is improved by the repetition of exercise. As the pattern of movement is established, it is simplified and becomes more efficient, and the conduction of the necessary impulses along the neuromuscular pathways is facilitated. Exercise or activities which at one time require concentration and much effort become with practice more or less automatic in character, and then further skill is developed, as for example in walking or playing the piano. Confidence. Achievement of the coordinated and efficient movement assures the patient of his ability to maintain subjective control of his body, giving him confidence to attempt other and new activities, together with the feeling of exhilaration and satisfaction when they are accomplished. For example, jumping a rope or shooting a goal. Basically, objective exercise and activities are used for this purpose because um, goal is set, and it is very basically the relaxing feeling for the patient too. Circulatory and respiratory cooperation during vigorous and prolonged exercise. It is apparent that speed and depth of the respiration is increased, so that the heart beat is faster and more forceful, and that heat is produced. Whereas in light exercise, these changes are so slight that they are not noticed. The need of the active tissue. The active tissue involved in muscular exercise require a free supply of oxygenated blood and removal of the waste products to enable them to continue their activity. To meet these demands and to keep pace with them, basically, cooperation of the circulatory and respiratory system is enlisted. Patient for activity. It is probable that cerebral cortex, which initiates the muscle contraction, also prepares the body to supply the need of the tissue concerned by communicating with the respiratory, cardiac, and vasomotor centers, which form part of the autonomic nervous system. Sympathetic fibers from these centers basically convey impulses to the appropriate organs, which, with the help of adrenaline, which is released into the bloodstream, produces widespread results. Basically, it is all possible with the communication of cerebral cortex with the other centers like respiratory, cardiac, and vasomotor centers. The results we obtain increase respiration, increase frequency of the heartbeat, a rise in arterial blood pressure, and redistribution of blood, so that volume of the blood in the muscle is increased at the expense of in the splanchnic area and the skin. All these changes occur merely as a result of anticipation of the exercise, as those who have taken part in the competitive sports may have been aware. Local circulatory changes in the muscles. During active exercise, the capillaries in the working muscle dilate and their permeability is increased. Many capillaries that are closed when the muscle was at rest become open and blood flows through them. In this way, we can say capacity of the muscles to contain blood is markedly increased, and the interchange of the fuel and waste products between the blood and tissue fluid is facilitated. Regulation of the circulatory and respiratory function during exercise. See, the venous return to the heart is increased during exercise, and results in an increase in the cardiac output. The increased venous return is caused by the pressure variations in the abdominal and thoracic cavities resulting from the increased respiratory movements, which exerts a pumping action upon the large vein, that action of the heart, and partly by the pressure of the contracting muscles on the thin walls of the peripheral veins. Basically, valves in these veins prevent regurgitation during relaxation of the pressure. So basically, they enhance the venous return. So venous return is increased, and that is the result of increase in cardiac output. Muscle contraction increases both the carbon dioxide content and the pressure of the blood, and both these factors basically stimulate the circulatory and respiratory system to further activity. The temperature that rise from in the body is kept within the normal limits by dilatation of the skin capillaries and stimulation of the sweat glands, thus enabling heat to be lost from the surface. So we can say overall effect of the exercise is active exercises increase aspiration to increase both the local and general circulation and to provide work for the heart muscles. These are the overall effects. Now start with assisted exercises. As the name shows, with the help of assistance. Active exercises are basically exercises performed by the patient or with the assistance of an external force as the therapist, cord and pulley, weight and pulley circuit, etc. Active assisted exercise are used when the muscles acting on one of the body levers are too weak to bring about the movement, or the muscles are too weak to control the movement adequately and for the restoration of the mobility. What is the principle of assistance? Look at this diagram too. When the force exerted on one of the body levers by muscle action is insufficient for the production of the control of movement, then an external force may be added to augment it. This external force may be applied in the direction of the muscle action, but not necessarily at the same point, as a mechanical advantage can be gained by increasing the leverage. The magnitude of this assisting force must be sufficient only to augment the muscle action and must not be allowed to act as a substitute for it. For it, as a passive movement results as the power of the muscle increases, the assistance given must decrease proportionally. Basically, in this diagram, look at this. That assistance is basically given to increase leverage, to provide additional leverage, and to obtain a mechanical advantage. What are the indications of assisted exercise? To assist movement in the case of muscle weakness when the patient cannot perform, to increase range of motion, to assist functional activities of ADL after removal of plaster cast, falling tendon or muscle transplantation as a method of muscle re-education. What is the technique? General plan is to ensure that inefficient muscles exert their maximum effort to produce movement under conditions designed to facilitate their action. The assisting force is applied only to augment this maximum effort and not to act as a substitute for it. In the technique, first of all, a starting position. Suitable starting position is selected. Comfort and stability for the body as a whole ensure that person's our patient's attention is concentrated on the pattern of the movement and effort required to perform it. Pattern of movement, this must be well known and understood by the patient. It can be taught by passive movement, or in the case of limb movement, by the active movement of the contralateral limb. Fixation. Adequate fixation of the bone of origin of the prime movers improve their efficiency. Whenever possible, this fixation should be achieved by the active means in order that weak muscles which may receive reinforcement for the action of those muscles with which they are normally associated for the production of the voluntary movement. When there is a tendency for the movement to be transferred to the neighboring joint to compensate for the inefficiency of the weak muscles, movement in these joints must be controlled or held back by the manual pressure or other means of fixation so that movement is pivoted at the required joint. So, if we obtain results in the required joint, then fixation should be required, and fixation should be achieved by active means. And if muscles are too weak, that active fixation cannot be achieved, then we use passive means. Passive fixation means that fixation by manual pressure, other means of fixation, for example plasters, splints, braces, etc. Sport. The part of the body moved is supported throughout to reduce the load on the weakened muscles by counterbalancing the effect of the force of gravity. This support may be provided by the physiotherapist's hand, suspension slings, a polished horizontal surface such as a re-education board, the buoyancy of water, or ball bearing skates. The advantage of manual sport is that it can be effective in whichever plane is most suitable for the movement. The antagonistic muscles. Every effort must be made to reduce the tension in the muscles which are antagonistic to the movement. This may be achieved by the variety of methods. For example, heat, massage, stretching, or relaxation technique. Starting position for the movement should be chosen to ensure that tension in these muscles is minimal. For example, a position in which the knee is flexed is suitable for assisting dorsiflexion of the foot. Traction. Preliminary stretching of the weak muscle to elicit the myostatic or stretch reflex provides a powerful stimulus to the contraction and traction maintained throughout the movement, and it helps to facilitate basically joint movement. Assisting force. The force used to augment the action of the muscle is applied in the direction of the movement. Type of assistance is manual assistance and mechanical assistance. Manual assistance, when the assistance is provided by the physiotherapist or patient only, we can say it as self-assisted exercise. Mechanical assistance, when the assistance is applied by the mechanical means as slings, pulleys, wheels, etc. The character of movement. The movement is essentially basically smooth as is the characteristics of efficient voluntary movement. It is performed in response to a forceful command which demands the patient full attention. The speed of movement depends upon the muscle involved as each has its own optimal rate of contraction which varies according to its structure and the load. Generally speaking, fusiform muscles contract rapidly and the multipinnate ones take longer. Very weak muscles cannot be expected to produce a sustained contraction, and therefore assistance is given in step with the contraction, which may only be evident as a flicker in the early stages, but as power increases, the speed of movement can be decreased. When assisted exercise is used to increase the range of joint movement, the natural rhythm, which ensures the fullest possible range, is most satisfactory together with the effort to increase the range with timed over pressure in the rhythm of the movement. The rapid movement sometimes advocate either results in a reversal of the movement before the limit of the range is reached or momentum gained is so great that it eliminates the necessity for muscle contraction and results in jarring of the movement from what is virtually a forced passive movement. So always avoid rapid movement. So basically, if we perform exercise in a natural rhythm, then it is possible to gain the range hopefully in early stages. Repetition. The number of times the movement is repeated depends upon whether it is considered advisable or injurious to fatigue the muscles. Therefore, the condition which has caused the weakness must be known and understood. In the case of stiff joints, there is no joint lesion Then the muscles are weak from disuse, then movement can be continued as long as the patient can be persuaded to make the effort to improve the range. Cooperation of the patient is very essential. During this type of exercise, the aim being for him to achieve controlled active movement without assistance. Concentrated effort is needed to encourage the muscles to do all they can to have the movement, so praise well earned should not be stinted. The ability to see the results and to feel what is happening is a great help to the patient, so he can be encouraged to palpate his muscles as they contract, and the use of mirror to observe the results may be helpful, especially when coordination is poor. Then basically it serves the purpose of reinforcement. So what are the fact and uses of assisted exercise? The working muscles cooperate in the production of movement which they are incapable of achieving unaided. Providing the maximum effort of which they are capable is demanded from the weak muscles, yet the assisting force utilized only complementary, these muscles will gain in strength and hypertrophy. This type of exercise may be used in the early stages of neuromuscular re-education to recovery from flaccid paralysis. And flaccid paralysis, as you know, it is lower motor neuron disease, and there is a weakness in the muscles, specifically group of muscles. And basically, so if we use the assisted exercise, we imply assisted exercise in these patients, then basically we can say recovery is enhanced. The memory of the pattern of the coordinated movement is stimulated by the correct performance of the movement, which the patient is unable to achieve without assistance. By frequent repetition of the correct pattern with the decreasing assistance, the patient may learn to control the movement himself, as the conduction of the impulses is facilitated in the neuromuscular pathways. So we can say assisted exercise may therefore helpful in training coordination. Confidence in the ability to move the painful joint is established when the patient observes the movement and the fact that muscle cooperate in producing it. The contraction of the agonist also ensures reciprocal relaxation of the antagonistic muscles, which would otherwise tend to go into protective spasm because of pain or fear of it. Knowledge that the limb is supported throughout, and that it can be rested at any point during the movement encourage the patient to attempt a wide range. When movement must be maintained in spite of pain in the joint, these exercises as active assisted exercise are very helpful. For example, rheumatoid arthritis, inflammatory arthritis, in which joints are swollen, red, inflamed. So if there is the one movement, and we have to maintain the movement in joints, then these exercise will be performed. The range of joint movement may be increased by these exercises, however, as both range and control often depend upon the efficiency of the muscles working over these joints. A technique which will utilize resisted exercise with these muscles is really preferable. When overpressure is given in an attempt to increase the range, results are probably achieved by the repeated mechanical stretching of the soft structures, limiting the movement. Assisted resisted exercise, basically it's a combination of resistance and assistance. This type of exercise constitutes a combination of assistance and resistance during a single movement, able to perform against resistance in the part of range, and resistance is required in some part of the range. As you can see in the picture, both resistance and assistance is applied at the waist, your center of gravity. Resistance, such as parachute, holds your back and forcing your muscles to exert more power, and assistance, such as elastic band, increases your maximum running speed, making your muscles and brain work faster than they are used to, leading to a faster moving and more capable body. So in we can say in assisted resisted exercise, we use a combination of assistance and resistance during a single movement. Hopefully you understand it, and remaining topics will be covered in upcoming slide.